All right, good morning, guys. I wanted to do a quick little video on a patient of Libby's. Um, this is Victoria. So a quick little backstory. Victoria was interested in going to the Dominican, I believe, to have an implant retained prosthesis made. Um, but we talked her off that ledge. So this particular case applies not only to an implant retained situation as we have planned here, but just any denture case. So this has less to do about the implants. It has more to do with prosthetic treatment planning for removable. With that said, it applies here. So the backstory is she had some dentures made at the local denture mill. Just look at that flange and just kind of recall what kind of situation that would create in a patient like this. So much of this has to do with the maxillary tuberosity. If we look at the model here, we can see how much premaxilla she has. We tend to see that situation, a situation like this where the bone is actually insufficient in this area, which is why acrylic is so good for lip support for these kinds of patients, because the acrylic will help support the lip. She has the opposite problem. She has too much bone. To look at her photo again, that's her side profile. Her lip doesn't look collapsed here. If anything, it looks properly patent. Why is this? Well, she has too much bone underneath it. So let's go to this image here. Sorry, I'm on two different monitors. All right, that's her without any teeth. Now, typically you would expect to see not to see the ridge. In this case here, you can actually see her entire ridge. So how do you get an immediate denture to be in the right position when you can't do a wax try-in on a patient? That's the challenge Libby and I have right now. So what I have come up with is this wax rim, and what we decided to do was have the lab actually take away the vestibule. They did that, and that was this try-in here. And unfortunately, she still has too much bone. So what we're going to try to do is modify the wax and the base plate in this area and the denture tooth so that we get this incisal edge to a proper position. Conventionally, we like to have a try-in where we get to see what the teeth look like. We're not going to have that opportunity because the denture base will not let us do a try-in. Sorry, the bone that she has won't allow the denture base to fit where the teeth are going to be, therefore we can't do a wax try-in like usual. So what we need to do is at least get the lab the incisal edge position of 8 and 9 in 3-dimensional space as close as possible. That might include us trimming this entire tooth down and then leaving a sliver of the incisal edge of the tooth in the wax in this area up here, so that when she's wearing it, we at least are comfortable with the incisal edge position of this tooth. Right now it's just too far down, as we can see. Most likely we're going to just reduce maybe half of this tooth and we'll be able to get it in the proper position. As long as we can get that and a face bow, then we can get the lab what they need to make an immediate denture for this case. But we're going to leverage digital technology and the CAT scan to help us get this case perfect. Topic for another day, but we're going to use Chrome. Chrome is essentially a CAT scan motivated surgical guide template where we're going to, I guess what we're going to do, I haven't thought through this part yet, but once we get that incisal edge correct, we're going to scan the patient again, and then we'll have the incisal edge position in the CAT scan in that perfect 3-dimensional space. We may want to, I have to talk to the lab about this, but we're going to want to also relay the face bow information to the CAT scan, and then the entire case is going to be built digitally based off of the CAT scan itself. What that's going to do for us is allow the lab to make a bone reduction guide so that we can get rid of this bone here, not only in a vertical sense, but an AP or sagittal sense. So we want to be able to reduce the facial bone, but we don't want to reduce so much that we end up not having enough room for the implants. Just to give us a preview of what that will look like, here's the bone in the premaxilla area. I envision us lopping this off right here. So why do we reduce bone much of the time? Regan and I talked about this yesterday. You want to reduce vertical bone when you have triangular situations. So this is very common with lower anterior implants where there's a triangle of bone. You want to reduce the tip of the triangle. In this case, it's not really a triangle. Let's just pretend that this section isn't there. This would be the triangle. That's more commonly the situation we see. We reduce that until we get a width buccolingual that is 4 millimeters greater than the anticipated implant that we're going to place. So let's go to implant. While I'm doing this, why 4 millimeters? Well, we want to have 2 millimeters on either side. That's in an ideal world. Much of the time we can't do that, but that's our goal. If we get 1 millimeter of bone on the facial and the lingual of the implant, then we're doing good. So that's this situation right here. So this is a 3.5 millimeter implant by 10.5 millimeters long. It looks like we'll be able to grab the nasal floor pretty readily. And we have ample bone on the buccal and lingual. This all gets removed. That's if we are doing implant-driven prosthetics. What we need to do is do the scan with this denture with the incisal edge position so that we can see it. We're going to be able to see it in this view here so that we know we have enough bone reduction in order to have enough prosthetic material from the incisal edge to the head of the implant, so that whatever prosthetic solution we choose, it has the material minimum thicknesses met. What do I mean by that? Let's just say this blue dot was the anticipated incisal edge, just for sake of discussion. If this implant, for whatever reason, was placed here, again, this dot moved with the implant, but let's just say it's this area here, the lab then needs to place acrylic in that little space. Let's say the minimum thickness of acrylic is 10 millimeters. We only have 3 here. That denture is going to break. The lab will basically say we can't do it. We can't fit all of the restorative material and keep the aesthetics in that proper position. Therefore, when we do prosthetically driven implant planning, we want to find the ideal aesthetics first, then go backwards and say, what's the minimum material thickness that we need for that material, in this case acrylic, and then we put the implant head there. Then we have to balance this triangle of bone. Let's just say that's where it was, okay? Well, we're not gonna do a nasal sinus bump, so then we need to go to the implant library and say, let's go to 7 millimeters. All right, that's prosthetically driven implant planning 101. You start with the aesthetics, then you work backwards to find out where you need to put the implant so that all of the criteria are met. Aesthetics, then the material thicknesses. Zirconia is less than acrylic, so there are times when you say, we have to do zirconia because zirconia is stronger when it's thinner, because we don't have anywhere else to go. There's situations where there's no bone here. Therefore, you can only place the implants in certain spots, which then leaves you with a certain amount of restorative material. You might be forced in zirconia, okay? So in the MISH textbook, they talk about inter-arch width. Certain prosthetic solutions have different minimal inter-arch width thicknesses. And I would encourage you guys to find that chapter in MISH and read it. Long story short, there's a certain amount of space in between the two arches from head of implant to head of implant that each material can perform at. Again, zirconia is one of the best because it's one of the strongest. A bar overdenture is one of the worst. You need a lot of inter-ridge space between the two to do a bar overdenture, because you need not only space for the bar, but you need space for the acrylic that goes on the bar that ultimately is the denture. All of those space requirements are driven from a CAT scan that is taken at the proper vertical. So you can see where this really starts to get complicated. And we're going to work on systems so that we get these patients the proper workup. This is one of those cases. So we will keep you posted, but I thought it was a really good time for us to say, what do we do when the patient has too much bone in the front? Okay, from a denture setup perspective. That's our way to do it. Another way to do it is to do the alveoplasty, do an immediate denture and hope that it looks good, take a final impression, and then do a new denture while the patient's healing. You know, you just try to rush it through the lab. That would get you closer, let it heal, and then start your records for a new denture. That would probably be the way most people would do it because it doesn't require a whole lot of thought. We're fortunate enough to have a CAT scan so that we can really start with the end in mind and work backwards. All right, hope all is well. And if you have any questions about this, I have the case up here. Let's chat.